So we haven't done that for a long time, and on this patient, I messed up. Actually, quite a few people messed up a little bit, and I thought I should probably share with everybody so that people won't mess up in the future when this happens, and learn from our mistakes. Mm, so, oopsie, I'm gonna here. So first, so this case has something to do with the CRT. It has something to do with severe uremia and DKA. So I thought I'm just gonna go a little bit at the beginning, review the CRT. So CRT comes in all different kinds of flavors, and I've noticed that people sometimes confuse these things. And sometimes we're doing one thing, but we're writing that we're doing something different. And I just want to make sure that like we are always writing what we're doing actually. So there are all these different kinds of continuous renal replacement therapy. There's SLED, slow, low efficiency dialysis. And that's the one that we do at University Hospital. And it is done with regular dialysis machines, just a different chip. And it's very similar to regular dialysis. It's just a little bit slower blood flow rate and slower dialysate flow rate, but still compared to true low efficiency like a CRT, it is still very, very efficient because your dialysate flow rates are usually like 200 per minute. So it's 200 per minute is how much per hour? It's 12 liters per hour compared to your real CRT, which is like 2 or 3 liters per hour. Something like that. So still pretty efficient. Then there's CVVH, which is continuous venous hemofiltration, and I'll show the picture and then that'll explain it a little bit better. And there's CVVHD, continuous venous hemodialysis, CVVHDF, continuous venous hemodiafiltration, and then there's SCUF, slow continuous ultrafiltration. So here's the picture. So we have our filter and we have our arterial line, which brings blood from the patient to the filter. It goes through the filter, and then we have our venous line that goes back into the patient after the magic happens in the filter. If we're doing just SCUF, slow continuous ultrafiltration, we are just pulling fluid from the patient. There is no clearance, or very little clearance. So we're just pulling fluid off from somebody who is very volume overloaded, but doesn't have any uremia issues or potassium or electrolyte problems. So that's SCUF. Now, continuous vena hemofiltration. What is the principle, like what is the mechanism of clearance? So here we're not only pulling the fluid, but we're also getting clearance. And by clearance, I mean that we're getting rid of the uremic toxins, fixing potassium, and things like that. So what's the mechanism of clearance in continuous venous hemofiltration? Is it diffusion? No. So what is? Convection. Right? And what is convection, like in simple words? Yeah, so basically what you're doing is you're giving fluid, nice, good fluid, a lot of it, to the patient, like 1 or 2, like 2 liters per hour, let's say. And then if you dilute the patient's blood with a nice fluid, it will look better, right? It will dilute that potassium and things like that. But you can't just keep pushing fluid at 2 liters per hour. So at the same time, you're removing 2 liters per hour in the filter, and you're diluting and removing, and eventually you dilute it to a nice blood constitution, right? So there's no diffusion going on. There's no diffusion. And it can be 2 types. So what types of CVVH are there? Based on where you're giving fluid. So there's a pre-filter replacement or post-filter. So in the pre-filter CVVH, you're pushing that nice fluid into the patient, into the arterial line, so before it goes into the filter. So let's say you're giving 2 liters per hour of fluid into them. It goes into the filter, and then you pull in the filter 2 liters of fluid again. But this nice fluid dilutes patient's blood and makes it look better. And then when you're pulling, you're going to remove some bad things. So this way, is it very efficient to do dialysis this way? No, actually least efficient, because from the clearance standpoint, this is probably the least efficient way to do it. Now there's you can give the replacement fluid post filter, but then you have to pull the same amount before you get that fluid in the filter. And so what problem can it cause then? I'm sorry? Clotting. Yeah, clotting. So basically you have to pull 2 liters before you give that fluid, so you concentrate the blood a lot. So you get better efficiency clearance, so you can correct potassium and acidosis better with this type, but the filter will clot probably. So, you can combine both. You can do pre-filter and post-filter, just divide that fluid. So this is your CVVH. I'm sorry?
Does BA here do?
God knows. Like they all have like next stage, Norton and VA, but it depends on the nurse. Like it can do that for sure. It can do that. But like if the nurse doesn't know how to do that, then they don't do that. Now, yeah, it either does CVVH or CVVHD. It doesn't combine them both. Yeah, but now the next one is CVVHD, which is continuous venous hemodialysis. So what is the principle of the clearance in here? It's diffusion. No, it's not. It's just diffusion. Yeah. So it's very similar to dialysis, but very, very, very slow, 24/7, basically. So there's no fluid that you're giving to the patient. Like you're not pushing fluid into the blood, pre-filter, post-filter. The only thing that goes on here is you're giving dialysate, not into the blood, but just into the filter around the capillaries, around those macaroni where the blood flows through. And then, when the blood goes through those like macaroni inside the filter and there's like good fluid around it, the diffusion happens, and that's how clearance happens. So that's your CVVHD. And now CVVHDF is continuous venous hemodiafiltration, long word, and it basically combines both. So you're doing both convection and diffusion. So basically you're giving replacement fluid and you're doing dialysate. And you can, like at Jewish hospital with a machine, you can do whatever you want. So you can divide it whatever you want. Usually we combine everything, then you don't compromise the clearance that much. You can adjust it depending on like if it's clotting or not, filtration fraction, and it gives you a lot of work to do with filter depending on how each patient does. So these are the types in the alphabet of the all CVVHDFs. So now we're going to get to the patient. This was a 36-year-old Caucasian male who had no significant past medical history, and he was transferred to Jewish hospital from outside hospital for need for acute dialysis and treatment of DKA. So some hospitals don't do dialysis, so they get transferred here. This patient, he got sick at the beginning of COVID-19, unfortunately, and then he was listening to the current guidelines where they said, like, if you get sick but you're not sick badly, don't go to the hospital, sit it out. So he was sitting it out at home. His family was encouraging him to go, but like he wouldn't go. And then eventually he got so sick that he got confused and lethargic, and family called EMS and they brought him into the hospital. At baseline, he was healthy, functional, working, had family, nothing wrong with the guy. The only thing is he had increased BMI. So on presentation, his vitals were like that. So his temperature 98, pulse 130, blood pressure 90s over 50s, and patient was completely unresponsive. Lab findings, his glucose was above 800, sodium 128, potassium 7.8, BUN 160, creatinine 9, bicarbonate 12, and then GAP 26. Anything wrong with these labs? Nothing is right? Yeah. So he basically just had a new onset diabetes. And he was not feeling well. He initially peed a lot. He got volume depleted, and sugars went up so high that now he's in DKA with horribly high sugars and acute renal failure. Um, so he was given quite a bit of fluid, at least 6 liters between the initial hospital and then after the transfer to Jewish hospital. He had Foley catheter placed, but there was no urine output after 6 liters of fluid. And from the history, it seemed like he had this problem for quite a while, like a couple of weeks. So the injury was probably going on for quite a while. Pressors were started, and patient was intubated for airway protection and because of the acidosis. And we were consulted to start CRRT, like some kind of renal replacement therapy. So we saw the patient, and we treated his potassium with temporizing measures. Primary team was managing his sugars. So we didn't, whenever somebody does something else, we don't get into their way. We try not to. So they started patient after he got so much fluid. They started him on insulin drip. And the hope was that insulin drip will help with his hyperkalemia as well. But unfortunately, potassium, even with medical treatment and insulin drip, remained above 6. That's because he just had bad kidney injury. His EKG was for prolonged QTC, and then we decided that we need to start some kind of renal therapy because he's going to get arrhythmia and going to be bad. So if you were seeing this patient, what kind of the modality of renal replacement therapy would you choose, and what kind of prescription would you write for this patient, and what are your most urgent goals in this patient? There's everything wrong, so what do you need to fix most urgently? Dialysis? Yeah, so hyperkalemia. So that's what we were thinking. It's resistant hyperkalemia. We have to fix it. I guess.
CRRT, but also IV kg changes from the probably it shows a higher potassium. Supposed to and having to change.
Yeah, so you would do CRT. So what prescription would you write? So probably Foxilum, right? 4Ks. Oh, no, okay. And what blood flow and what? So what dose of CRT would prescribe? So what is the dose of CRT? Do you know, guys?
So repeat when he's making your.
Oh,
So
okay.
when they say something, you need to repeat it.
Oh,
so the response.
So Dr. V said that he would choose continuous renal replacement therapy opposed to dialysis because he is unstable. He would, although potassium is high, he would choose still higher potassium bath because he's on insulin drip, and that can lower potassium. So now we have to decide what dose. So what is the dose of CRT? I'm sorry?
The numbers, the blood flow,
So blood flow is not your dose of CRT. No, it doesn't go.
So it's usually 15 to 20 cc's per kilogram per hour.
Of all the replacement fluids and
Yes.
and the dialysate. So it's only your replacement fluid and dialysate. So if you're prescribing, let's say, a liter pre-filter and 1,000 of dialysate, your dose is 2,000 cc's per hour, and it should be around 15, 20, or 25 maybe. There were these studies. It's always better to prescribe a little bit more, like 30 at least, because it never runs like the way you prescribe. People go for x-rays, if they clot, so you never deliver what you prescribe, so prescribe a little bit more. So the good default would be like 25 to 30 per kilogram dose of all the fluids. And what determines the efficiency of CRT? Like, if you're not getting enough clearance, what will you change the prescription? Would you go up on the blood flow rate? Would you go up on the replacement fluid, dialysate? Yeah. So blood flow rate has basically nothing to do with your efficiency in CRT, as opposed to hemodialysis. So in hemodialysis, if you want to increase efficiency, you go up on the blood flow rate. In CRT, going up on the blood flow rate, the only thing that it helps is it prevents clotting. So doing the higher flow rates, like let's say 230 instead of 200, will prevent clotting, but it's not going to give you more clearance. It's going on your replacement fluids and on your dialysate. So I deviated a little bit. So what dose would you prescribe this guy? 30 ml per kilogram. So he's about 100 kilos. So you could do 3 liters. Okay. So let's see what we did. So we used CVVHDF because that's what we usually do. We start with it Jewish, and then we adjust whatever we need. And the goal was to lower potassium and treat acidosis while avoiding rapid decrease in BUN, because his BUN was what, 160? Why did we want to avoid rapid decrease in BUN? Yeah. Disequilibrium, yeah. So, and actually it's in my notes, but I'm trying to avoid it. And so we prescribed blood flow rate 220. That's a good default one. And the total prescription was 1,800. So it's a little bit underprescribed for such a big guy, but they did it on purpose to avoid lowering BUN too fast. And we used 4K solution for dialysate, and actually we chose 0K solutions for pre-filter and post-filter initially, because he was on insulin drip already and he was not coming down, so we thought that we need to lower it fast. And since we didn't prescribe a lot of prescription, it will take forever to correct it. So we thought that it's going to do it faster. And we didn't order any UF, and we told them to continue with IV fluids for now, because he didn't require a lot of FiO2. Now, clinical course. So patient's sugars were brought down to almost normal of insulin drip within 24 hours. Anion gap decreased to close to normal. His BUN decreased from 160 to 80 within 24 hours. And the next morning, the nurse noticed that patient's pupils blew up and that he became non-reactive and lost gag reflex. And then they rushed him to the CT. What do you think they saw on the CT? Yeah, here. I guess just believe it that it's cerebral edema, but I guess the ventricles are dilated and the gyri, and he had actually herniation. He herniated his brain. So what has happened? Yeah. So it was dialysis. Why does it happen?
I think from what I understand is, at least with the BUN, it's that the BUN doesn't cross the urea is not able to cross the blood-brain. So it creates an osmotic gradient. So if you pull off fluid and there's increased urea in the brain cells, then it'll flush fluid into the brain.
Yeah, exactly. Yeah. So first of all, how could you suspect that somebody has the disequilibrium syndrome? It comes like in different grades and different stages. It can be really bad, like ours, or it can be a little bit less bad. So the symptoms would be nausea, vomiting, headache, dizziness, cramps. Who doesn't have cramps on dialysis? Agitation, then disorientation, confusion, tremors, and visual problems. And then patients get change in mental status, seizures, coma, and death. So all the range. So the first time dialysis disequilibrium syndrome was Yeah, that's another thing. Yeah, I'll talk about it too. Yeah. No, yeah, very good. You guys like get it all. So the first time it was described actually in 1962, the disequilibrium syndrome. I didn't know they did dialysis then. We'll have to ask Chip how he did it then. Then, and it is manifested by neurological decompensation, and it can be different severity. It can occur during dialysis, but it can happen later on after you did it. And it happens when you remove urea fast. So urea actually can go into cells and out of cells freely, but not very fast. It is permeable to the cells, but not very, very fast. And there is a problem with people with end-stage renal disease. There is aquaporin channels in the brain cells which let water in and out. They're actually upregulated for some reason in dialysis patients, so water can go very fast. But the channels for urea channels are actually downregulated. So it's even slower, like the crossing of the membrane. So this just shows the picture of urea transporter in normal people, and then aquaporin channels. So aquaporin channels let the water in and out, and urea for urea channels. And uremia, as you can see, there's a lot of aquaporin channels, but there's no urea. Is somebody talking? So when you do hemodialysis, you decrease the urea concentration in the blood here very little. But you still have it in the cells, and it can squeeze through those few channels. So, and you have a ton of aquaporin channels, so the water just gets in there. So I just looked at that article because I was very curious. The first description of disequilibrium syndrome. So it was in 1962 in the Lancet, so a good journal. They did a really fun study. We could never do it. I mean, like this these days. But basically, they checked their CSF fluid urea levels before and after dialysis. So basically, we would be LPing people before and after dialysis. The CSF levels, urea levels, were comparable.
Somebody came off mute.
Oh, really?
Get rid of them. Okay. So if you ever need to do that, you can hold tab and you can see who's giving you feedback.
Oh, okay. So CSF urea levels remained much higher than blood levels after the dialysis in these people. So it's not only the decrease in urea that precipitates the disequilibrium syndrome. There can be other factors that will contribute to it, and people are going to be much more prone to it. So severe hyperglycemia, just like our patient had. So basically, you're removing glucose and you're decreasing osmotic pressure that way as well intravascularly. So you're increasing the water shift into the brain. Volume depletion. So if you expand volume very fast, also it will contribute to it. And also, it is more likely to occur if the sodium is going up slower than the urea going down. So if somebody is hyponatremic, actually. During dialysis, the sodium will go up, but if it's not going up and you accidentally choose to use like a low sodium bath, that will contribute to it too. These other contributing factors. So if somebody, just in general, when urea is high or glucose is high or like sodium is high for a long time and osmotic pressure is high intravascularly, brain actually develops some mystical ideogenic osmoles inside the cells to avoid water shifts. but they don't get removed with dialysis, so they stay there and they, I guess, pull water into the cells. So this also just shows risk factors for developing disequilibrium. So first dialysis treatment, people will get that more often. Children, old people, then of course high BUN, hypernatremia. So if somebody's hypernatremic and you drop their sodium during dialysis, hyperglycemia. Now metabolic acidosis, it actually really plays the role. So correcting acidosis fast will increase the risk of disequilibrium. The thing is, when you're correcting acidosis, you're actually making cerebral acidosis worse, because I guess it gets converted to CO2, and CO2 freely goes into the brain, and then it gets converted to like hydrogen, and so intracerebral acidosis gets worse with correction of acidosis, like with bicarb drip or dialysis. So some people recommend to use lower bicarb baths in these cases. And then intracranial metabolic acidosis increases risk of edema. Now, of course, if somebody had pre-existing neurological problems, they have little brain reserve. And then some conditions increase permeability of the brain barrier, like meningitis, vasculitis, tumors, HUS, TTP. So some misconceptions about DDS. Some people think that it can only occur, it cannot occur in acute kidney failure, that it only occurs if somebody has chronic renal failure, which is totally not true. People think that CRT is not going to cause it because it's slow and inefficient. It's not so slow and inefficient, and especially if there are any other underlying problems. People say that like if you reduce it just very little, you're not going to get it. But if you have other problems like hypernatremia, hyperglycemia, then you can still get it. So how do you prevent it? So what should he have done?
Is it possible to adjust the bath with
No, it comes in fixed bags. So Foxilum and Prismasol has sodium concentration of 140. Mm-hmm.
Probably.
What, hypotonic?
If you're correcting hyperglycemia,
if you give hypotonic solution, you'll give more water, so there's going to be more water to cause edema.
I think what may be helpful is that you get a baseline serum osmolarity, and if you do decide to start CRRT, then again, the seems like the whole injury is all from osmolar is basically osmolar injury. So then you may consider 3% saline just to kind of maintain, kind of slowly reduce the serum osmolarity over longer time rather than rapid osmolar correction.
I knew HITARP is smart. Anything else? Yes, Emily? Yeah, God, to tell the truth, God knows what they used. I don't think they have like protocols now. They were saying I don't know how they do it, but sometimes we were so concentrated on our thing that we don't look what they do. We totally, absolutely had to cooperate, and they were bringing in glucose down, we were bringing urea down, and we were not talking to each other. So that's a problem. So they should have slowed down the correction of it. Mm-hmm. 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 Yeah. Mm-hmm. Mm-hmm. Mhm. 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 Not the change. Change. Mhm. Yeah. 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 So this would have definitely prevented it and helped, like if they lowered the sugar much slower. So that's another lesson. Okay. Anything else you guys can think of? Okay, so let's see what we can do. So first of all, try to decrease the clearance of urea if possible by decreasing the prescription and the dose. Be even more gentle. I thought we were being gentle, but I guess we should have been even more gentle with the clearance. And then increase the time over which you do that clearance. And then add somehow a never osmotically active substance to the blood. So how much of a reduction of urea is actually safe? You can correct urea a little bit faster than sodium, and you're not going to get into the trouble because the reflection coefficient is 0.44. So I mean, it's just permeability into the cells. So you can correct urea a little bit faster than sodium and not get into trouble. And still. So the number is somewhere between 56 to 67 per day if there's no other complicating factors. So choose a smaller dialyzer. The thing is we're pretty limited with CRT. We have one dialyzer and we have 2 fluids, but we can decrease the dose of it. But for dialysis, for example, you can choose smaller dialyzer, and for regular dialysis, you can decrease the blood flow rate. For CRT, you don't decrease the blood flow rate, you decrease the prescription, so replacement fluid and dialysate. So if a patient, if you're doing dialysis, for example, for a uremic patient who's horribly volume overloaded on 100% FiO2, then maybe do ultrafiltration initially and not dialysis. Remove and then just do dialysis later. Then you can also replace urea with a never osmotically active substance, and that will keep the fluid intravascularly instead of going to the brain. And your options are either sodium or mannitol. It's a pretty old study, but that's the only randomized study that there is for this purpose. So they were doing continuous EEGs on people with high ureas and on dialysis, and they were they were doing either high sodium bath or low sodium bath. So high sodium bath was somewhere between 144 to 154, and then the low sodium bath 133. And there was much less EEG changes when they used high sodium bath in these people. And also none of these people developed any symptoms compared to like low. So choose high sodium bath on dialysis. On CRT, unfortunately, we don't have an option of higher sodium bath. Now the use of mannitol, you can use preventively intravenous mannitol, 1 gram per kilogram. And in another study, they looked, so if they used mannitol, the osmolarity decreased by only 4.3 compared to 10 if they didn't use it. So you can use that, you can do that. And then the symptoms of disequilibrium also were much less common in these people who received mannitol. Now, so I guess we could have thought about it and we could have used mannitol. Well, first of all, decreased sugar slower, then maybe used mannitol, used less clearance, so a slower prescription. And then the other thing, and I thought this was really interesting. Oh, I'm sorry, I didn't put the reference, but this is a recent study from, not a recent report from C. Jason, from Ashita Tolwani. She does like 1 million CRTs a day at the University of Alabama. And she actually explained it more for the correction of hyponatremia, how to not overcorrect it in CRT. But you can apply it in our situation where you want actually to cause hypernatremia a little bit more. So I think this is really handy and interesting, and we could probably use it. Since we can't choose higher sodium baths, because we don't just have these options, it's either fluoxetine or prismasol, which is 140 sodium, we can actually use hypertonic saline to be infused post-filter into the patient's bloodstream. And then that will increase your sodium concentration that goes back into the patient through the return venous line, right? Not to shoot like in the dark completely, but to get like some kind of idea of what sodium concentration you're going to be giving, there's a formula that you can calculate it. So so the sodium concentration at the end of circuit, so basically end of circuit is the venous line that goes back to the patient. So sodium concentration in the venous line on CRRT can be determined by total sodium in circuit per hour divided by total therapy fluid amount per hour. So most commercial fluids have concentration of 140, let's say fluoxetine prismasol. So, and then 3% sodium chloride sodium concentration is 513. So if we do CVVHDF, continuous vena diet filtration, which we do at Jewish, and we do pre-filter solution at 1000, dialysate at 1000, and infuse 3% sodium chloride post-filter at 100, which becomes your like post-filter fluid replacement, let's say, then a returning serum concentration can be calculated. So 140 milliequivalents per liter times 1 liter will give you pre-filter sodium content, plus 140 times 1 liter, which is dialysate sodium content, plus 513 times 0.1, which is your post-filter replacement sodium content, divided by the total fluid volume, which is 1 plus 1.01. And then it comes up to 157 milliequivalents per liter. So that's what you're infusing, 157 milliequivalents per liter at about 200 cc's per hour. And then, there's formulas where you can calculate the change in sodium with the given sodium concentration in the solution and with the rate. Your RB, like orange books or purple books now, or your Google MD, you can look at that and calculate how much your sodium is going to change. But that gives you some idea. I found this really, really handy, helpful. Like in people, for example, in opposite situation, if we have a person with severe hyponatremia and we're starting them on CRT, we can do the same thing. We can do like fluoxetine with prismasol for pre-filter dialysate, and then we can do the post-filter replacement fluid with hypertonic solution, let's say D5W. And we can calculate the sodium concentration in the venous line using this formula and kind of sort of predict the change in sodium. Yep. And that is it. Any questions?
Sodium low to begin?
His sodium was low, but it was pseudo hyponatremia because of sugar of 800. Like it was like 126, so like it corrected to kind of normal.
But the trends over time, what's the numbers?
Oh, I'm sorry, I didn't put it. I didn't do a very thorough work job on this.
I've been learning this from nephrologists. If by itself was
Yes,
without any other things. I don't know whether it was API or not.
Yeah, so it's hard to tell if it's we that caused this problem or if it was from, but I think it's from like both. So I guess the lesson learned number one: look what other people are doing, and talk to them.
Hey, Lina, it's Dawn. If this is a case I remember, which this might be a different case.
Yeah.
I recall his sodium was actually high if you use the outside hospital numbers, but I could be wrong. And I thought this patient, we did stop CRT and tried giving hypertonic saline.
Yeah, then we restarted.
Overnight.
We did try, but it did increase it. But then potassium went up again, and we had to restart it again. And So his urea did go down pretty quickly, even with very little of CRT. It did get corrected.
Because he was still on pretty low clearance. He was like 600.
But I guess it's insulin drip also that eventually helped it.
So it's probably multiple factors, but yes, it does. You know, his starting osmolarity was extremely high, so I think understanding that going in is key.
Hey, I'm good.
You have to stop recording.